probing depth and achieving clinical attachment level gain. So it seems on both sides of the Atlantic that as of today, you and I don't have a lot we can do to modulate the host other than subantimicrobial dose doxycycline. So how are we going to treat these folks? Well, it's reasonable to consider short-term systemic antibiotic or host modulation along with aggressive mechanical debridement to help control inflammation in patients that don't respond to conventional therapy, that have severe disease, especially in the presence of other systemic inflammatory conditions, and who are smokers or poorly controlled diabetics with mild to moderate disease. As I consider these consensus statements and what we have today to treat our patients with aggressive periodontal disease and severe disease in presence of other chronic inflammatory disease, I have to ask myself, you know, I wonder why, if the only thing that we have that's been shown to allow us to somewhat modulate the host is subantimicrobial dose doxycycline, why haven't we as a profession really embraced this? And as I did all of my reading on inflammation and tried to look at the medical literature as well as the dental literature, I can tell you our medical colleagues seem to be embracing this more than we are. Well, I don't know. There could be a number of reasons. Perhaps you're like me. I've used it, and you know, I didn't really see too much of a difference, and I don't think many of my patients felt there was much of a difference. There could be a number of reasons for that. One is it could be it doesn't work, but there's so much evidence out there that it makes me wonder. It could be that, you know, 80–90% of our periodontal pockets are inactive at any one time, and maybe we're treating the wrong people. You're not going to see a positive change on inactive pockets anyway. Could be that compliance is an issue here. You know, for this stuff to work, it takes a long time for connective tissue to turn over. Maybe our patients are really not taking it like they should, even though they're telling us they are. Or it could be that it is working and we just don't have the chairside diagnostics to determine this. Rheumatologists have known for years that they can't look at outward signs of inflammation, redness, swelling, and know what's going on as far as connective tissue breakdown in the joints. So perhaps we can't either. Now, certainly in the future, we are probably going to have ways to be able to look at biomarkers, to make sure that our treatment is keeping these biomarkers low. But today, you know, we don't have that. You know, unfortunately, there's lots of questions. We've come a long way from calculus irritating the gingiva, causing the disease, but there's still a lot we don't know. Fortunately, we may have drugs out there that are helping us treat these difficult to treat patients and not even know it. Ken Corman and I talked about this when we did our Vision 2020 lecture 3 or 4 years ago, that there are drugs and technologies being developed for systemic diseases that will treat and prevent periodontal diseases inadvertently. You know, perhaps the question shouldn't be who will be treating periodontitis in 210, 220. Is it going to be general dentists? Is it going to be hygienists? Perhaps the question is who's treating it today that we don't know about. Bisphosphonates slow the progression of periodontitis. Statins dramatically reduce bone loss. These drugs are being taken by millions and millions of individuals, and it has the potential to reduce the severity of periodontal disease before these patients ever reach our office. On top of that, there are drugs that are being developed that will be used to treat periodontitis intentionally. The most active drug development today is in oncology and inflammatory disease. You know, it takes a tremendous amount of money and resources to get a new drug through the FDA. Periodontal market's not big enough to do that. But my friends, inflammation is inflammation, and the drug companies know that. And when you treat inflammation on one chronic inflammatory disease, it's going to have an effect on inflammatory periodontitis. I think this is an important kind of conceptual thing. It's a broader view of the periosystemic connection, that there are common critical pathways of multiple diseases, and you treat one and it's going to affect the other. And certainly we'll be seeing more and more of this in the future as well. Well, both the speakers touched on this. Also, when we're treating our patients in our office, are we also reducing systemic inflammatory diseases? I mean, I'd like to think we are. Probably a bit premature for that. But I think if we will focus as practitioners on treating inflammation and not infection, it really puts us where we want to be in the periosystemic connection, and that is that the mouth is connected to the rest of the body, regardless of what the outcomes really end up being. I do think there's compelling evidence that there are strong associations. You know, as was mentioned, we have 3 good studies showing that treatment of periodontitis improves endothelial function, reduces the chance of cardiovascular disease. We have good studies showing that treating our patients' periodontal disease makes glycemic control better. We're in a discovery phase here, and it's probably going to take another 10 years or so before we can determine, are there really strong connections? But what's the worst that can happen? We treat their periodontal disease. What if a connection's found? How will that affect your periodontal practice? Well, all of a sudden, you're going to be referred many more patients that have chronic inflammatory diseases. All of a sudden, medical protocols are going to include diagnosis and treatment of periodontal disease. But diagnosis and treatment by whom? You're going to have more collaboration with your physicians on treatment, patient care, research, but more collaboration also means more competition with oral surgeons on who is the go-to source for dental knowledge in the medical world. We're probably going to see physicians start to treat some forms of periodontitis. And if we're not better at managing and at least recognizing the systemic components, we could end up being a technician for the physicians in this. So it's not all positive. It will definitely change our profession dramatically if these connections are associated. And we need to be prepared for this. Well, if that is how we might change the treatment of our disease patients, how does inflammation affect our regenerative therapies? I mentioned that I was in my residency in the late 70s. I started in 1977. The year before I started, there was a very interesting article by Rosslin et al. In Journal of Clinical Perio in '76. He showed that after flap osseous surgery with no regeneration, that they got radiographic evidence of bone gain, of regeneration. I mean, this really stood our profession on its ear at this time. Now, there was a lot of people that says, hey, yeah, but this isn't real world, because you know what else they did? They brought these patients in every 2 weeks for 2 years to do home care instructions and prophylaxis. But I think they certainly showed that in an environment with little to no inflammation, that wonderful things happen. So perhaps we should be thinking about reducing the inflammation, concentrating on getting in an inflammation-free environment, and then adding our cytokine reservoirs, or then adding our growth factors. You know, inflammation is a strong mediator in the healing response. And look at my patient here, where I've gone in, you can see the large intrabony defect that we debrided. We grafted it with a growth factor, recombinant PDGF. And here at 2 years, you're seeing good radiographic evidence of the fill of the defect. At 3 years, even more consolidation, and even more impressive, we're seeing changes in positive radiographically in the furcation. So something's going on very wonderful here. But I also want to draw your attention to my preoperative view and postoperative view. See any inflammation there? Look at this is a 9mm probing depth. See any bleeding there? Inflammation may be extraordinarily important in our regenerative results. I mean, if you think about research right now, we can regenerate almost anything on a preclinical level. You know, using growth factors, signaling molecules, live cell therapies, you know, it's something. But have you ever thought about why we have difficulty and why we've not been able to show that we can grow bone with BMP around teeth? Maybe it doesn't work well in an environment of inflammation. The future's bright, though. There are all sorts of drugs that are out there that block the bone resorption pathway, that maintain bone once you have it. You do your regenerative procedure, now you give them this drug. It's to keep the bone. Animal research even shows that bone grows back spontaneously if you eliminate inflammation. All that's in the future, though. Well, how about this question? Should new knowledge about inflammation change the way we maintain our patients? I have to tell you that it is this question that's made me think more than any of the other questions about maybe changing the practice, my practice. Is there a greater role for drugs, both local and systemic, and how about those questionable teeth? You know, I have a large, mature maintenance practice. And I see this all the time, as I know you do. You have patients who have done very well over the years, and all of a sudden their disease reactivates. It's not because they've forgotten how to brush or floss. It's because as we grow older, we change. Changing may be a little more fat around the middle. Changing may be osteoarthritis or diabetes. All of these things alter the systemic inflammatory balance. And when we see a reactivation of the disease in our patients, it may mean that there is something going on systemically as far as inflammation that's allowing that to happen. And that these patients may be at more risk for problems outside the oral cavity as well. So we want to make sure that we don't take this lightly. That when our patient's disease reactivates, that we need to take this inflammation seriously, both because of local and systemic consequences. You know, there is emerging evidence by Steve Offenbacher and other people that bleeding on probing, bleeding scores, may be good predictors on systemic inflammation and your chance of developing severe periodontitis. That if you have high bleeding scores, that's a good indicator of systemic inflammation. Low bleeding scores correlate with biomarkers for low systemic inflammation. And that we perhaps don't want to think of gingivitis as this innocuous thing that we thought of in the past. And that in our maintenance population, that if you have patients that are high risk, you know, smokers, diabetics, people who are not responding well to traditional periodontal therapy, and perhaps patients with other chronic inflammatory diseases, that you need to treat these people more aggressively if their disease begins to come back. You know, don't just decrease their interval for the maintenance. Don't just do more home care instructions, but you need to think about, let's make sure we've debrided these patients carefully. Let's make sure that we consider either local or systemic antibiotics. Let's make sure that we think about maybe toothpaste with anti-inflammatory agents, or we think about essential oils that we've known for 20 years that have anti-inflammatory abilities. Bottom line is, we may want to treat these people a little more aggressively than we have in the past. And here is really the sticking point of what's really got me thinking about my practice. You know, I doubt I'm the only person in this auditorium that has quite a few patients on my maintenance program that overall, you know, they're doing pretty good, but they may have, you know, a few teeth here, a few teeth there that just stay chronically inflamed, no matter what I do, no matter what they do. Maybe even a tooth that's basically hopeless. But, you know, the patient says, no, doc, it doesn't bother me. And because, frankly, I don't know what else to do, I've done it all. And because I think I'm doing the right thing by them to treat them conservatively, that I say, you know, as long as that tooth's not bothering you, and as long as we don't see that it's beginning to adversely affect the adjacent teeth, we'll just keep on doing like we're doing. I say that every day. I had a patient a few weeks ago that really drove this home and made me think. I mean, this guy is sitting in my chair. He tips 400 pounds. You know, I worry about my chair. So, you know, he's obesely overweight. He's high stress. He's a computer tech guy that is, you know, if you believe him, he's the most high-stress guy in the world. He has sleeping problems. He has a history of cardiovascular disease. He's diabetic. Now, he is compliant. He comes in every 2 to 3 months. But I'm thinking, are you crazy? You're maintaining these chronically inflamed teeth when he already has all these systemic markers of inflammation, and I'm adding to this? So it's making me rethink that perhaps in this situation, in patients that have other chronic inflammatory problems, that I should not be adding to that inflammatory load, and that either I need to go in and retreat this with newer technology than I had in the past, or I need to get these teeth out of there. Now, we've got fairly reasonable studies suggesting that implants do well in patients who have had refractory periodontitis. You know, these are hyper-responders perhaps. We don't know why. Maybe bacteria is different around implants, maybe because they don't have a PDL. But the bottom line, they do pretty well. The implants do well. Now, I don't want anybody to leave this lecture and say Mike McGuire is suggesting we go back to the focal infection theory and we start taking all these teeth out. That's not what I'm saying at all. I'm just saying that if you're like me, you know, we have this problem where we think retreatment is a personal failure. I think as a profession we need to get beyond this. I don't think our physician colleagues feel like this. And if we have areas in our patients with chronic inflammation, we either need to retreat them with newer technology or we need to face the facts that in this case the patient would be better off without these teeth. We also could do a better job at risk factor modification. This isn't anything new. You know, we've struggled with this for years with our patients. We have our traditional risk factors, our smoking, our plaque, our diabetes, the genetics. But also, as the two previous speakers have pointed out, there's a whole new list of risk factors that we maybe need to consider. Increased weight around the middle increases your inflammatory load. Poor sleeping patterns, same thing. High-fat diet, same thing. Not all of these have been studied as it relates to periodontal disease, but you know, these kind of things, all of these increase the systemic inflammatory load. And if we're going to try to tip the scale on our patients so that if we're doing a regenerative procedure, tip the scale to try to reduce the inflammation, then at least educating our patients about how all of this works together and about how they can make lifestyle decisions, lifestyle changes to reduce the total inflammatory load could have an impact on the outcome of our treatment. And then finally, are periodontists at risk for not referring periodontitis patients who have other chronic inflammatory conditions to physicians? You know, I thought of this because, you know, we as periodontists have knocked our general dental colleagues for a long time for not referring periodontitis patients early enough, for not diagnosing them appropriately. Are we at risk for this? Should we be taking a more detailed systems review during our patient exam? You know, we're realizing that the periodontium is part of a systemic stream of events, yet we're only monitoring a very small part of it that has systemic consequences. Well, I don't think, and none of the people I really would talk to think that there are markers that we can use to be looking at these, and that probably doing CRP levels and those kind of things are not appropriate. But, you know, could we be doing more in our medical histories to pick up these people? I think as a group, we periodontists probably have a more complex and more comprehensive medical history than our general dental colleagues. But if you're like me, you really don't do much of a systems review. Maybe at next year's AAP meeting, we should have a course on history and physical. Really, if you look at a lot of these things, trying to pick up the diabetic phenotype and the cardiovascular phenotype, most of these things can be evaluated just through questionnaire or visual evaluation. But it wouldn't kill us to occasionally take a fasting blood glucose level either. You know, people used to laugh at dentists taking blood pressures when they started. What are you doing taking a blood pressure? You're just a dentist. As was mentioned, the Scottsdale Project, I think, was a great first initiative to try to bring together physicians and dentists and periodontists to see how can we co-manage these patients. And while the evidence was maybe not strong enough to make strong guidelines, they came up with some things that I found useful. For example, they suggest that dentists may consider referring to a physician perio patients who've not had medical evaluation within 2 years, or two or more of the following: either greater than 50 years old, they're at risk for diabetes, they have hypertension, dyslipidemia with a family history of cardiovascular disease or stroke, that they're tobacco users, or a history consistent with cardiovascular disease. Well, what's the flip side? How are our physician colleagues doing out there? Dr. Zarek said that, they're not looking in the mouth too often, and if they do, they probably don't know what to do with it. Well, you and I are not going to teach them how to probe. That's kind of silly. And the American Academy of Periodontology, I can tell you, for many years have tried to reach out. We had a program a number of years ago where we tried to talk to some of the other medical associations and the medical auxiliary associations. And it basically fell on deaf ears because they wanted to know where the evidence is. Well, the evidence is getting stronger. It's not quite there, but it's getting stronger. And we certainly have the patient's interest. And that is driving it a whole nother direction because the patients are demanding these kind of things. But I think that we are moving in the right direction with this. And again, the Scottsdale Project suggested to the physician